Hello, and welcome to the 9th International Congress of Vitamin D. In this keynote speech, we are going to discuss about vitamin D and the immune system with a special emphasis on the relevant doses and the serum 25-hydroxyvitamin D levels necessary to overcome infections. In the learning objective of this program is to discuss about key concept and the relationship of biology of the vitamin D to immunology, evidence of causality of vitamin D to COVID, and importance of calcifidiol in emergency situation to overcome infections. D3 is considered as a dietary nutritional supplement in most countries. The highest recommended doses available is 50,000 capsules, except in India is 60,000. Important that vitamin D has a stable shelf life and has a wider therapeutic index and broader benefits. Therefore, there's a minimum or no adverse effects of drug or drug interaction present, as well as it's an inexpensive therapy. In addition to vitamin D, also important K2, vitamin A and C in smaller quantities, and particularly the magnesium is crucial for not only for vitamin D, but also for its vitamin D receptor activity in creating the autocrine and paracrine function. Whereas zinc and selenium are antioxidants are necessary to prevent intracellular replication of viruses, together with other micronutrients like quercetin, etc. The third level, it's also necessary to have nano quantities, so tracer quantities of like T3 and iron, dietary iron, etc. can also would contribute to the actions of vitamin D in general. Here's some studies we did a while ago to show the prevalence of vitamin D deficiency in United States, especially in New Jersey. Overall, there are about 1/3 of the population is vitamin D deficient. And more importantly, 2/3 of the population or more are vitamin D insufficient, and particularly in nursing homes and disability centers, over 85% to 90% of the in-residents are vitamin D deficient. You may recall that on 2020 COVID crisis, and the vast majority of the people who died, or the elderly who died, are actually from the nursing home, almost 70% of all deaths in 2020. So these are vulnerable population, and we'll discuss what we can do to overcome that tragedy. This is possibly the first publication regarding the vitamin D and COVID, and actually written on January 6th of 2020 and published on the 3rd of March 2020. This article predicted that coronavirus is going to be a pandemic, and there will be a stock market collapse because of the various components, particularly the supply chain issues. And also it predicted that the vaccines will be available in months instead of years as in the previous infection. It also discussed that vitamin D is a major solution to the problem, but to date, after 2.5 years of having pandemic, still that has not materialized. Now, certain groups and racial and ethnic disparities present in the population basis. One of the common denominators in these groups are this low serum 25-hydroxy concentration. This is due to multiple reasons, and one of the commonest reason is having a darker skin, therefore less ability to produce vitamin D through their skin, especially those who live with darker skin, who live in the temperate climates, in the northern climates in Europe. So consequently, their vulnerability to develop chronic diseases and infection, including sepsis, which is very important and kind of neglected. So they have a consistently low serum 25-hydroxyvitamin D levels. This is a study from the National Institute of Health and Nutrition's examination survey, so-called ENHANCE study, and showing the racial and ethnic disparities of having low serum vitamin D. What you're looking at is a percentage of people on the y-axis against a deficiency status or vitamin D status on the x-axis. When you consider the deficiency status, as you see, the people with the Black ethnicity and Hispanics has the highest proportion of deficiency. In contrast to when you look at the sufficiency, you can see that the white race or ethnic group has the highest sufficiency level, no matter what country we have studied. Let me give a couple of examples. This is from UK studies looking at the age and death of doctors who died from COVID during early 2020 period. In the case of whites, the white doctors, the average of age they died is from 88 years. So most of them are actually retired and not practicing medicine. Whereas the Black, Asian, and ethnic minorities, the mean death occurs around 58 to 60 years of age. So there's a 30-year difference in age of death of white versus the non-white races in UK in a comparable socioeconomic group. So the difference is between these two groups are the doctors who died early at age had the darker skin color and hence low vitamin D in their circulation, increasing their vulnerability. So this slide was published a couple of months ago in Nutrients, where she's showing the three commonest vitamin D components, the D3, which is cholecalciferol, calcifidiol is a 25-hydroxyvitamin D, and calcitriol, which is the dihydroxy of that. So the two important things are, the categories are, is the concentration in the blood. When you look at the D3 and 25-hydroxyvitamin D, both has a nanomolar concentration in the blood circulation. This is in contrast to calcitriol, or 125, has a picomolar range of calcitriol, which is about 3 orders of magnitude less than the 25-hydroxy D and D3. Second important thing is actually in D3, the half-life is about 24 hours, whereas the calcitriol is only a few hours. In contrast, in the calcifidiol, it generally lasts about 15 to 22 days. So the key benefits of vitamin D with reference to COVID include the stimulation of the both adaptive and innate immunity, and it is a potent anti-inflammatory and antioxidant. So it also enhances antimicrobial properties like producing antimicrobial peptide against both viruses and bacteria. Consequently, and suppressing of inflammatory cytokine, it also reduces the risk of cytokine storm. So having adequate vitamin D levels also increase in the formation of the neutralizing antibodies as well as soluble ACE2 receptors. All of these are highly beneficial against or fighting against the viral diseases. So this slide summarizes what we know to date, the best or the optimum level of 25-hydroxy D necessary to overcome infection. This is considered now as 50 nanograms per milliliters or 125 nanomoles per liter. Needs to stimulate immune cells to become a robust immune system. So in addition, it also stimulates the innate immunity and kickstart the production of antibodies against uh, uh, offending agent. The vast majority of people who develop COVID-19 complication and even died from COVID, they had a compromised immune system, one or the other. Again, the common denominator of all these problematic cases was the severe vitamin D deficiency. The death generally occurs when the person is having serum 25-hydroxy concentration less than 12 nanograms per milliliter. Therefore, what is logical is to provide what which is lacking in these patients, particularly the vitamin D, which is a very economic agent available or nutrient. So we are supposed to generate our vitamin D through the ultraviolet rays, but many of us are not getting that opportunity because we work on indoor system, and those who even work outside or moving outside try to avoid exposure to sun, like using umbrellas and comprehensive use of UV blocking ointments and creams. So in the skin, it produces the pre-vitamin D, then it's into vitamin D, and in the liver, it converted to 25-hydroxyvitamin D, whether it's through the dietary D3 or D2 commonly, or the supplements of D3, it passes through the same mechanism or activation into 25-hydroxyvitamin D in the liver, which is a rate limiting factor. It doesn't happen immediately. It takes generally 24 to 36 hours to get it initiated. And then it will be released to the circulation, mostly bound to the vitamin D binding protein. And then at target cells, it produces calcitriol. Here, I like to emphasize the key differences between the hormonal calcitriol in circulation by definition and the non-hormonal form of calcitriol generated within the peripheral target tissues. So the hormonal form is produced by the renal, in the kidneys, so renal tubular cells, and that is crucial for maintaining the calcium, magnesium balance, bone homeostasis and calcification of cartilage, and the maintenance of the entire muscular system. So that is a function of the hormonal calcitonin. However, the level, as I said, in the circulation of calcitriol is a way insufficient to get into peripheral target cells, because many of these cells do not have a acute transportation mechanism, unlike the renal tubular cells and like fat cells and muscle cells. So in these tissues, target tissues, as your intracellular production of calcitriol is totally depending on the availability of D3 and 25-hydroxyvitamin D in the circulation, and that enabling entering these two compounds into immune cells. That's fundamental necessity to activate the autocrine and paracrine functions, and it helps the immune and other symptoms to function properly. So in kidney, it produces the hormonal form of calcitriol, which is acting on the musculoskeletal system. Whereas in the peripheral target tissues, calcitriol produced is really driven the autocrine, paracrine signaling system of immune cells to do whatever they are supposed to do. So once the D3 and 25-hydroxyvitamin D enters into immune cell, it converts into calcitriol, and that boosts the immune system and controls respiratory pathogen. In this particular case, we are looking at the COVID-19, but also has effect on any coronavirus, influenza virus, as well as bacteria like tuberculosis. So collectively, it prevents the occurrence of cytokine storm, prevent the microvascular thrombosis and ARDS and pneumonia, the two most common causes of death in those with COVID, SARS-CoV-2 infection. and allow them to rapid the recovery without complication of those who have adequate level of vitamin D. So circulatory calcitriol has virtually no effect on immune cells as their concentration is in picomolar concentration and is insufficient to get into immune cell. It's a very important fact when you're trying to treat or even prevent viral infection of people. So therefore, the immune cells are purely depending on the circulatory D3 and 25-hydroxy concentrations to come inside the immune cells to generate calcitriol within these cells and to boost the autocrine and paracrine signaling. So when the people with vitamin deficiency, it's not happening. Therefore, it is again logical to provide the vitamin D as a substrate into adequate amount into people so that they can generate their own calcitriol intracellularly. I'll come back to the effect of calcifidiol. In emergency situation, you can bypass the 3 or 4 days that takes to calcifidiol vitamin D to activate it, whereas calcifidiol can get activated within 4 hours and boost the immune system within a day. This slide we are looking at is 25-hydroxy vitamin D versus the month of the year. As you see that there's a big drop on the level of serum 25-hydroxy D during the winter-spring period because there's no exposure to viable or the adequate amount of UVB rays from the sunshine. And this is also coincide with the annual flu season, which most of us believe is partly or at least mostly due to the low vitamin D concentration. And during this particular period, the immunity of the community, most people will go down dramatically. If you look at even at the beginning of the winter period, there are only about 50% of people in US, for example, are vitamin D sufficient. Concerning, assume that the 30%, 30 nanograms per milliliter is sufficient, which I will show you, which is not the case. Here's a chart published previously and show the different viruses and the name the number of months on the top. So as you see in the green area, that's where all the viral respiratory infections are the common, except for the enterovirus, it can happen at any time during the year. So let's look at what are the actions of vitamin D within immune or peripheral target cell. Here is in the case of immune cells and how it produces autocrine and paracrine signaling. Let's start with the 24-hydroxy vitamin D and D3 entering into immune cells. It's mostly due through the diffusion, but also it can enter with the for example, 24-hydroxy D bound to vitamin D binding receptors, vitamin D receptors, and it can actually internalize as a complex into the immune cells. So this will be converted through the CYP27B1 into calcitriol. It then binds to the calcitriol receptors called vitamin D receptors, and then it enters into the nucleus to have a nuclear gene interaction. So this produces various signaling system for autocrine within the same cell's activity and generation of antimicrobial peptides, etc., and also has a paracrine effect on the adjacent cells to stimulate them to do the right thing, what we expected. In contrast, in renal tubular cells, you get the endocrine or hormonal signaling coming out, which come into the circulation. It disseminated via blood throughout the body, and as I said before, it acts on the musculoskeletal system as end organs. So when SARS-CoV-2 enters into a human, in those with a vitamin D deficiency, will have an additional damage or the down regulation of the ACE2 receptors. These are soluble receptors that can neutralize viruses. And then It increases the angiotensin converting enzyme, thereby increasing the angiotensin 2 within the body. That is one of the major signals to increase the cytokines and cytokine storms, increasing those oxidative stress and apoptosis. They're all pro-inflammatory cytokine-driven issues. So combination is just increase the severity, complication, and deaths from COVID-19. In contrast, when you have a vitamin D sufficiency, it downregulates the renin-angiotensin system, increase the ACE2 receptors, and reduce ACE and the angiotensin 2. Consequently, it increases the antioxidant peptides properties and anti-inflammatory activities. It increases the antimicrobial peptide and reduces apoptosis and generation of anti-inflammatory cytokine. The outcome is reduced COVID severity and almost elimination of the COVID deaths because there won't be any cytokine storm. So I'll put the concept into one slide here. When you look at the vitamin D deficiency, if you look at the CD4 cell, for example, it's this NFA, NF-kappa B driven system, where you have a higher amount of Th1 cells and Th17 cells because of the lack of vitamin D. So both these are really driving the inflammatory pathway. Whereas when you have a vitamin D sufficiency, it converts from Th cell to Th2s and Th17 to Treg cells. These are anti-inflammatory. So what we call is a switching system from inflammatory to anti-inflammatory. This has the multiple benefits in the immune system, thereby actually helping people. As I said, the vitamin D promotes the Th2 cells, Th helper cells, to produce the non-inflammatory cytokines and reduce inflammatory cytokine. Similarly, the Th17 cells now converted to Treg cells, which produce all the beneficial cytokines to overcome the viral and bacterial infections. So let's look at very briefly why the efficacy of COVID vaccine has reduced and in fact is failing right now against the Omicron variant. So these are a number of reasons. I just summarized three of them. The primary failures of vaccine is failed to maintain the immune system's alertness, so losing its efficacy because it loses the recognition of the viruses in particular areas like spike protein because of the mutation happening in a frequent fashion in these SARS-CoV-2 virus. So after a while, right now, after a year and a half of using COVID antibodies and very little recognition happening with the antibody generated with vaccine against the SARS-CoV-2 viruses. This is completely contrast to the natural immunity, and that raises the antibodies to co-antigen and the nuclear capsid antigen, and as well as the surface antigen of spike protein. So it's a much more comprehensive antibody cocktail generated following the natural infection. So the terminology outbreaks used by the media and WHO, etc., are basically is characterized to the peaks of COVID-19 is not appropriate. It's really perhaps should be renamed as a vaccine failure. So the second concept I like to introduce is vaccine alone will almost never be able to control the pandemic. We have more than adequate information on that, about almost 500 published articles. In some countries, despite 80% of the adults have been vaccinated, they still continue to have breakthrough infection. So this is a contrast to some countries still have less than 10% of the vaccine. Actually, their outbreaks are even less than those countries with the 80% or 70% vaccination. Secondly, vaccine alone is incapable of generating herd immunity, again due to multiple reasons. But most importantly, the duration of functional antibodies produced following vaccine is weeks to months, not as some other infection for lifelong antibody production. Secondly, as I said, this immune recognition of the viruses by these antibodies has failed. So what world need is to affordable alternative strategies and early therapies to overcome COVID-19, especially for lower and middle income countries who doesn't have to spend $500 patient of antiviral agents, whereas vitamin D, ivermectin, cost no more than $1 or $2 per patient. So let's look at the effects of various causes which worsen the situation. Here what you're looking at is aging and comorbid condition or the pre-existing condition associated with vitamin D deficiency. So as I said, most of the people who succumb to COVID-19 in 2020 and early 21 are the senior citizens, all, and we know that they all had a very low ACE2 concentration, which is protective, and they had multiple comorbidities from hypertension to diabetes to abdominal obesity and other conditions. So these disabilities and increasing age, together with the environmental issues, causes increased risk for COVID-19, its complications, and indeed deaths. So these are all could have been prevented if the respective governments and the WHO took the appropriate action in early 2020 to advise the public and the government to increase the population vitamin D concentration. That would have avoided completely the need for any lockdown or curfews. We lost that opportunity more than once. In this slide, what you're looking at is the age-related mortality from COVID-19. As you said, the mortality rate goes up like that after basically about 65 years of age. So if this is a case, again, why the senior citizens are more likely to develop complication and death? As I said, the two common reasons are they have a low ACE2 receptors to neutralize viruses, and secondly, they don't have most of them have a severe vitamin D deficiency, therefore weakened immune system. So what about the pre-existing condition, the second most important cause for death following COVID? If you look at here, the blue bars are the pre-existing condition, and red bars are those with no comorbidities, relatively healthy and non-obese patient under age, with different age groups. And so see that people with the comorbidities have a significantly higher death and death rates, no matter which country that you're looking at it. So we should have focus on those with not only the elderly, but also the vitamin D deficiency and those with the pre-morbid conditions of any of the common chronic diseases like kidney failure, lung failure, heart failure, etc. Here's one example considering the obesity or the BMI about 25 kilograms per square meter. What you're looking at is percentage of prevalence in adults in a given country. In the y-axis, we can see that the reported COVID-19 deaths per 100,000 population. As you see, when the obesity percentage goes up, it's applicable to individual and population obesity, the COVID-related deaths escalated. So again, there's one group the government should have targeted to boost their immune system using higher doses of vitamin D. These deaths could have been prevented significantly. So let's move on to the relationship between the vitamin D and serum 25 concentration. As you may know, there's the relation between the dose administered and the serum 25 concentration are not linear. It's a curvilinear. Higher the doses, smaller percentage of gain of serum 25-hydroxy vitamin D due to multiple reasons, physiological reasons. So if you look at, for example, even if you look at the 5,000 dose of vitamin daily dose, it takes several weeks to months to achieve the necessary target of 50 nanograms per ml in the circulation. So in an acute situation, midst of the COVID, just giving even 5,000 a day is really insufficient to protect from the COVID and other infection, because it takes several months to achieve the necessary target levels. Therefore, you need to have a booster amount of what I call upfront loading doses. In this case, like we can do from 100,000 to 400,000. You can raise the level within 3 to 4 days to above 50 nanograms per ml, and then you can maintain the same level with either 4,000 or 5,000 international units per day, which is protective against the entire duration of taking medication. So let's look at the relationship between the serum 25-hydroxy concentration and the SARS-CoV-2 complication, including deaths. This slide basically shows that the COVID-19 deaths per million in this axis and the percentage of death here. So when you're looking at the graph, it is not striking. However, we look at the two extremes. For example, the percentage of people with vitamin deficiency, especially in a Nordic country who had a higher intake of fatty fish, and also vitamin D supplements are kind of a routine, had a very little compared to the countries like UK, France, and Belgium had a higher death rate because their vitamin D deficiency percentage in a given population is much, much higher compared to these countries. So what are the beneficial effects of vitamin D on the immune system in preventing COVID-19, specifically against complication and deaths? So there have been multiple studies that show that there's a strong correlation between low vitamin D in blood. I'm talking about 10, 20, 30 nanograms per ml, etc., and the severity and mortality from COVID. So this causality, actually, low vitamin D increases the complication and death from COVID-19. Vitamin D concentration above 50 nanograms per ml is the minimum necessary to protect from SARS-CoV-2 complication and death, because we know now that it actually prevents not only blood clotting, but also cytokine storms happening. So it's a very protective agent that costs no more than $1 or $2 per patient, per person to be treated. So unfortunately, even today, the current recommendation by the health organization like WHO and many NIH and other organizations, vitamin D blood level, they consider 20 to or 30 nanograms milliliter is adequate. But question is adequate for what? All evidence shows that it is adequate, but only for the musculoskeletal system. As I showed, it's for the endocrine or hormonal function of vitamin D, but not the peripheral target tissues like immune cells. So regression analysis have suggested the theoretical zero mortality, in fact, approximating at the level of 50 nanograms per ml. So this is there are several studies like this showing that higher the level, lower the complication and mortality from COVID. So basically, they all concluded that there's a strong evidence that vitamin D deficiency is a predictor, because it's a causative to develop more complication and dying from the infection. In addition to vaccination, the vitamin D also necessary to maintain the robust immune system and for generation of antimicrobial peptides. So this is applicable for any vaccination. The vaccination alone is insufficient because it does not stimulate appropriately the immune system. Because as we said before, vitamin D and other micronutrients are necessary to have a robust immune system, so that then having vaccination will have the most benefits. Let's go through a few of the recently published data on this. Here what you're looking at is a COVID-19 test positivity in the y-axis and the vitamin D level on 25-hydroxy vitamin D on x-axis. So this clearly shows that around 40 nanograms ml, you get about 7% or plus positivity rate, and the positivity rate doubles as the level goes down. And you get the minimum or the baseline infectivity rate when you achieve the 50 nanograms per ml. This is kind of baseline infectivity, because vitamin D is not capable of preventing completely for getting COVID. What it does actually is it heightens the immune system and thereby reduce or prevent the complication and deaths. In this study, what you're looking at is the risk for hospital-acquired infections against the serum level of 25-hydroxyvitamin. This is a neat study by Qureshi et al. Published several years ago now, and people have been unfortunately overlooked. Here what you're looking at is that 50 nanograms per ml, again, people achieve the background level of infection of 2.5% infection rate. Whereas at maintaining the level at 30, you can see that it's a 6-fold increased risk of having infection. Whereas when you're down to about 10 to 12 nanograms per ml, there's more than 10-fold of risk of infection from due to vitamin D deficiency. Similarly, here what you're looking at is the COVID-19 deaths versus the serum 25-hydroxyvitamin D, and against the complication from infection. For example, in children, Kawasaki disease and multisystem inflammatory disease. It's very similar to the previous study, except that it's from 2022. It shows that higher vitamin D level, higher than 50, reduce the death rate by at least 6-fold, and some studies have shown up to 14 to 18-fold reduction of deaths at a cost of $1 or $2 per patient. This is a very recent study published on the hospital length of stay given on vitamin D group versus placebo. It's a controlled clinical study. You can see, you don't need a statistic. You can see that the people who treated with vitamin D, it's a significant earlier recovery, and there's more prolonged course of disease, as in this case of placebo. This slide has two publications I summarized with the two slides. On the A, what you're looking at is the clinical outcomes versus the serum 25-hydroxyvitamin D. So higher the seriousness of the clinical disorders like outcome, ICU admission and the death, and lower these patients had the vitamin D. In the Alcala study, what we're looking at is vitamin D. They gave a calcifidiol, which is a rapid-acting vitamin D, and that group has a 75% reduction of death compared to the placebo-treated control group. So last slide I'm going to show you on these, because there are so many have published recently. What you're looking at, the mild, moderate, severe, and critical the cases of COVID-19 against the serum 25-hydroxyvitamin D. So differences between these groups are all statistically significant. Higher the serum level of vitamin D, lower the serum vitamin D, higher the complication and death rate, as shown by the others too. Just one slide from the vdmeta.com website, just to show that there have been a lot of publication for clinical studies using vitamin D for early treatment, late treatment, and for prophylactic. Except for these 3 studies that had a very poor or the bad study design, all of them were shown positive results. So, beneficial effects of vitamin D in patients with COVID-19 infection include the reduction of the ICU admission, as well as the length of stay, and indeed, death rates are significantly less. This slide I again borrowed from the C19 Early Home website. It shows the importance of treating early in the disease, just like in any other viral illnesses. This is nothing unique. Earlier the intervention, better the efficacy of preventing complication and death. And you waited till about 6, 7, 8, or 9 days, then your treatment is basically become ineffective. It doesn't matter how costly that intervention is. So I'm going to show you some series of forest plots that show the effectiveness of circulating 25-hydroxy level in reduction of the severity, complication, and death from COVID. These are from this particular group, which published recently. The first one showed the effects of the high vitamin D level, its reduction of the relative risk by almost like 200%. Next slide shows the relative risk of reduction in the supplemented versus unsupplemented group. Again, as a marked reduction of complication and deaths from COVID in vitamin D supplemented groups from multiple studies. Again, you look at some of the studies included here has shown a positive effect of relative risk reduction in the vitamin D supplemented groups. And the last of this series showing the vitamin D levels and again the deaths related to COVID-19. It's a significant improvement or the reduction of deaths following vitamin D treatment. So currently the prophylactic dose of vitamin D, most of the clinicians and scientists are recommending is about 5,000 once a day or 50,000 international unit once a week, or ideally every 10th day. As I said before, is the caveat that 5,000 a day alone is going to take several weeks to few months to raise vitamin D deficiency, the correction of vitamin D deficiency. Therefore, by alone is insufficient to achieve the goal, improve clinical outcome. So these patients need to have a booster intake or higher dose intake of vitamin D at the beginning. At the first, get to know that patient is got infected or PCR positive. Then you can actually follow it up with the 5,000 or 4,000 international on a daily basis to maintain the level above 15 nanograms per milliliter. This is a study by Ekwaro et al. Just showing the relation between the oral dose of vitamin D versus the serum level achieved. As soon as you see, it's not a linear relationship. If you give, for example, if you give a 3,500 level daily, it should be able to achieve something like 14 nanograms per milliliter. If you give 7,000 a day, which is about 50,000 a week, can easily achieve the required level of about 50 nanograms per milliliter. However, even if you increase to 15,000 a day, still you're no way near your toxicity you're talking about here, you get about between 60 and 80 nanograms per milliliter. Toxicity will not develop until the level maintained about 150 nanograms per milliliter in susceptible people, not in every person who had such high levels. So quickest way to boost the immune system is to use calcifidiol, which is a partially hydroxylated vitamin D, average about 1 milligram, generally 0.5 to 1 milligram. But here's the calculation, 0.014 milligrams per kilogram body weight. So it's easy to administer in the right dose for the right weight of the patient. The beauty of that is that it acts within 24 hours to increase the serum 25-hydroxy vitamin D level and thereby stimulating or boost the immune system within a day rather than take about 5 or 6 days with oral standard vitamin D. Let me give a couple of examples here. So serum 25-hydroxy level after 200,000 IU one-time dose for in this example. Whereas if you look at the calcifidiol together with vitamin D, you can increase the level within few hours and maintain it longer as well. Then what you need to do is actually do the daily administration of reasonable amount of vitamin D to maintain this level all the way rather than getting back to the initial starting level. This is another example that you can show that calcifidiol administration will increase the level within 4 hours to the desired serum or protective level of serum 25-hydroxyvitamin D. So the currently recommended doses for PCR positive symptomatic persons is doses between 100 to 400,000 as a single dose or divided dose given on a daily basis to rapidly increase their serum 25-hydroxy level. Goal is to boost the immune system. Nevertheless, this must be followed up by the daily or weekly maintenance dose of vitamin D to have a better effects on the longer duration. There's no adverse effects one can detect at this suggested level. So here one slide just to show the cost benefit or cost effectiveness. The antiviral like these two products cost about 500 to 700 US dollars per person per dose regimen. It reduced the hospitalization by 50%. It's not bad. However, if you give the ivermectin or vitamin D, which costs about $1, it reduces the hospitalization by 75% of the dollar, compared to 50% of hospitalization by spending 700 US dollars. So one course of treatment of this, you can actually treat 700 patients and make them better. So I'm going to show you, this is a recent published paper in June 2022, basically to show you 3 tables that you can use it for your clinical practice to assess how much vitamin D need to be given to a given patient to achieve the desired therapeutic level. Here's the table 1 here. What you're looking at is the vitamin D doses needed to be given when the serum 25-hydroxy D concentration is known, as in this first column here. So, for example, if you know the level is something like a 10 to 15 nanograms per mil, there is a deficits about 1 million unit in this particular patient, assuming that it's a 70 kilogram person. So these patients can be treated with the 200,000 interaction units orally, and then give a number of capsules, 2 capsules as 50,000 per week for 8 to 10 weeks to achieve and maintain the level to the desired duration. And then you can revert back to 5,000 a day or 50,000 once a week regimen. Table 2 shows that when there's no vitamin D level is available, as in most of the developing countries, it's expensive test, and in fact, it's not necessary to do for patient before you start treatment. So this chart based on the body weight basis, here we'll look at in the first column here, and there are 2 categories. First, in the children, so the weights are different clearly, and that doses calculation based on the 70 international unit per kilogram basis. The total dose necessary. As you see that the daily doses and the once a week doses to achieve that. In the case of adults, is again based on the BMI in this case, or the body weight, either way. And then you can calculate the amount of daily or once a week doses necessary to maintain their therapeutic level of vitamin D throughout the pandemic. Finally, the table 3 shows the body weight bit calculation of calcifidiol. So weight in kilograms and pounds, and the dose of calcifidiol necessary and equivalent of vitamin D loading dose. Again, if you get an example of a 60 to 70 pound adult, the person, usually children, 0.5 milligrams is more than sufficient to achieve that goal. Whereas non-obese, obese 70 kilogram person need 1 milligram of calcifidiol or more, depending on the circumstances. So in summary, there's a strong evidence that there are strong association between serum 25-hydroxyvitamin D and COVID severity as well as COVID deaths. Better the vitamin D status will have a better the immune system. Therefore, the lower the risk of complication and deaths from COVID. Taking 5,000 a day, while it's useful, it's going to take some time before achieving the therapeutic level of 25-hydroxyvitamin D. So emergency situation, loading doses like 100 to 400,000 can be life-saving, especially if you don't have the calcifidiol available to use. So 98% of the published studies show inverse correlation of serum 25-hydroxy concentration with the risk of COVID severity and death. So lower the level, higher the risk. So in general, I kind of hypothesize this particular part on an outcome based on the serum 25-hydroxy vitamin D. If you're having the level of 50 nanograms per milliliters, hardly anybody will develop symptoms. It's like a mild flu, or many people didn't even know that they had an infection. Here you get a mild disease, moderate disease, and severe disease with the complication, and deaths usually occur when the levels are not corrected and it was below 10 nanograms per mil. So in summary, vitamin D deficiency must be corrected early as possible, specifically in the elderly. And administration of loading doses are useful, and also prior to vaccination, at least 3 days prior to vaccination, if you get loading doses, vaccine outcomes, so the antibody formation will be significantly higher, improved. The alternatively, 0.5 to 1 milligram of oral calcidiol can be calculated on weight basis, should be administered at the time of the vaccination to boost the value of the vaccination in maintenance of the immune output. So these strategies will save lives and indeed the economy and prevent the need of lockdown. So let me summarize by saying that vitamin D deficiency-induced disorders are common but preventable. In the case of sepsis and infections, particularly for COVID-19, maintain the level above 50 nanograms per milliliter, prevent symptomatic disease, complication, and avoid deaths. Thank you and have a great day.
Hi, hello. We have listened to these two talks, and there are, I'm sure there are a few questions to answer. So we have here are questions like, is it for you, Dr. Sunil?
Yes, sir.
So can you see the questions?
I don't see the question.
So the questions, thank you all. I would like to ask, how much sun does the body need to produce sufficient vitamin D by itself?
Oh, that's a wonderful question. There are two scenarios. One is the duration of the sun exposure, depending on the density of the melanin of the skin or the skin color. and also the time of the day of the exposure. And what matters is, see, to get the sun rays, UVBs, at the acute angle from the sun on your skin. So what you call it a zenith angle. So generally the best time to expose the sun is between 10:30 in the morning and about 1:30 in the afternoon. The problem is in Gulf countries, sunshine could be pretty harsh at that particular time. So the other option is to have them exposed to sunshine on a small period, like 10 minutes at a time, to build up your time necessary, like 30 to 40 minutes, for example, to get that period, because staying there continuously for 45 minutes is not easy. And the second important thing is actually to need to expose your skin surface, at least about 1/3 of the skin surface, to the direct sunlight, not through the windows or glass, because that UVBs get cut off. If you do that, that means many studies have been done that have shown that anything from 2,000 to 10,000 international units can be generated in a day by such exposure. But again, the caveat is that the level of international unit generated based on the density of the skin color. Thank you.
Thank you, Dr. Sunil. There is another question for you, actually. Can you please clarify more about the new recommendation for vitamin D deficiency? At what value we could rely on food sources, and what value supplementation is needed?
Yeah, unfortunately, the food has contained very little vitamin D, except for sun-exposed mushroom and the fatty fish like a salmon, mackerel, and that kind of thing. The milk in most countries are now fortified with vitamin D, but unfortunately, the level of fortification of dairy products and other food components are something like the 1/3 of what is needed. So it's too little of fortification. It's part of the problem of not getting the population vitamin D high. So basically, as I showed in those last three slides, the tables, the average about 70 kilogram person, non-obese patient, going to require between 4,000 and about 8,000 units a day, on average about 5,000 international units. That should be adequate to maintain the serum 25-hydroxy vitamin D about 50 nanograms per ml, which I think is a therapeutic level necessary during the COVID and other infectious pandemic and epidemics. Back to Dr. Amar. Andrea?
Okay, thank you very much. There is another question for you, is about whether vitamin D is a toxic and a blood level of total vitamin D in different age groups. It is a critical, whether it's critical levels. It's a critical levels. Sorry.
Again, another wonderful question. There no toxicity from vitamin D has been demonstrated or reported under 150 nanograms per milliliter. In fact, there have been only about 50 to 100 cases globally entire period. And those, the 95% of them are levels about 200 nanograms per milliliter. So it's very high. So we're talking about 500 nanomoles per liter, very high doses. But again, to confirm that is due to vitamin D deficiency, it has to be accompanied with hypercalcemic symptoms and signs and symptoms to confirm that is really due to vitamin D toxicity, which is extremely rare on the recommended doses.
Okay, thank you very much, Dr. Sunil. I think there is another question, which is actually for me, but I'm not sure I'm going to be able to answer this question. So I might need your help here. because I'm a statistician, really. I don't know these technical things. So saying if vitamin D levels cannot be checked or monitored in a population, I think this might be possible. It's not possible. It can be checked through different like studies. You could randomly select from different population and from the population, and you can measure vitamin D. This is possible. But then the next part is what are the correct loading and maintenance doses? So I cannot answer this because I'm a statistician. So what are the correct loading and maintenance doses? Dr. Sunil, what do you think?
Thank you, Dr. Ahmed. Again, part of that I covered in the lecture towards the end. And particularly, I gave that the table 2, you can go back and look at the nutrient paper we published in June this year. It's clearly illustrate to the table 1 and 2. So if you know the serum level of 25-hydroxy, you can use a table 1. If you don't know the vitamin D, 25-hydroxy vitamin D level, then you can go to the table 2. So that's a body weight or BMI based dose calculation. It's pretty easy actually. We have done this for almost 25 years. We have been practicing the same, using the same these two kind of tables, and we haven't had any problem. So the doses, what you need is, as I said, in the body weight basis is the best way to go. Otherwise, on average, you can say that non-obese 70 kilogram person, about 5,000 or 50,000 international units on every third day, or at least once a week. And the important thing that will appear, those who are vulnerable, the comorbidities, the elderly, and especially the obese people, going to need more than 2 to 4-fold higher doses to maintain this particular therapeutic level to overcome infections or any other chronic diseases.
Thank you very much. Very useful. I don't know if there are other questions to answer for us, but I mean, just to add for the first part of the question, like the vitamin D deficiency data we used in this study was collected through literature review, and this was collected from different study conducted in the Arab Gulf countries. Therefore, it's possible, I think, to measure vitamin D in average on population. I don't know if there are more questions to ask. Any additional questions? Okay, then in this case, like, do you want to summarize 1 minute, and I summarize 1 minute, Dr. Sunil?
Yeah, sure. It's not a big deal to control the pandemic like this once health authorities people understand the biology of not only vitamin D, but also the immunology of the viral disease what you're talking about it. That was a fundamental flaw we had during the 2020 and even today. And virtually none of those the decision makers in like WHO, CDC, FDA seems to either doesn't want to understand or doesn't understand the biology behind the vitamin D and how it helped our immune system, the boosting the immune system to keep us healthy. So that's, I hope this kind of information will improve. If we know that, it'll be so much easier to control the pandemic without any lockdown or curfew, etc., which had been harming countries in their economies and livelihood and basically destroy the supply chain entirely. We can do without it. Thank you.
Yes. Thank you very much. Very useful and very important summary. For me, I would like to add on that. I mean, one reason for we did that is because what we said, Dr. Sunil, we started with vitamin D, and we understand, like, because I'm working with Dr. Fatma Lanout. She's an expert in vitamin D.
Mm.
So we understood from the beginning that vitamin D might be useful, and therefore we didn't have data. We started to use population data. And I believe that if COVID-19 became not very risky, killing people, but actually lockdown again is really damaging economy, as you said. And I
Yes.
think what we learn from this pandemic, vitamin D is important. And we might think in the future, if there is any other pandemic, similar pandemic, we might think on vitamin D to be used as a supplementary during or even before the pandemic.
Yes,
Thank
Dr.
you.
Hamad.
Yes.
Very good.
Thank you very much.
What an amazing session that was. Thank you very much to our panel of expert speakers. I know our dear viewers are enervated, so we will take a short break, just enough time to grab a refreshing cup of beverages and sustenance. We will be back for the next session of today's agenda in 15 minutes.